The metabolic syndrome is named after Raven, and we're going to discuss Gerald Raven from Stanford University, who, in my view, deserves a Nobel Prize, but he's probably not going to get it, and I'll explain why. But he begins in 1960 to look at the question of what is insulin resistance, because he reads a textbook in the 1920s which says there are two types of diabetes. There is the insulin resistant form, and there is the insulin deficient form. We call the insulin deficiency type 1 diabetes, and the insulin resistant form we call type 2 diabetes. And he said, but what is insulin resistance? Because it had never been described. And he has spent the last 50 years describing insulin resistance. And this syndrome, which is now named after him because he was the first to put all the conditions together, are hypertension, high blood pressure, visceral obesity, elevated blood triglyceride concentrations, and low HDL cholesterol concentrations. In addition, the small LDL particles, which are the toxic atherogenic ones, and we call that pattern B, and these are the lipoproteins, as we mentioned, because these are prone to oxidation, and it's when they become oxidized that damage the arteries. These are increased by a high carbohydrate diet but reduced by a high fat diet. I'm specifically talking about small LDL particles because we're going to discuss them at length, and because they're completely ignored, although they were recognized by Krauss in the 1990s. He said a high carbohydrate diet increases the production of small LDL particles. And he said we have to consider that is toxic to the arteries. But it was ignored because it was again coming out at a time when we were pushing the high carbohydrate diets. So that is the metabolic syndrome. And in essence, it is all the markers, all the symptoms of insulin resistance. And so here's Gerald Raven, and this is an article about him, an editorial about him, to make the point that this is not Tim Noakes telling you about insulin resistance. I'm giving you information about one of the most important discoveries in medicine, in my view, in the last 50 years, but it's something that we've ignored. And the reason we ignore it, I have no idea, but I have some suggestions. So here it is. Gerald Raven could easily be epitomized as the father of insulin resistance. Please understand he's a professor of medicine at Stanford University, one of the 3 top universities in the world. So this is not a crank. He's not a madman. And so it says Gerald Raven could easily be epitomized as the father of insulin resistance. In addition to emphasizing the role of insulin resistance, compensatory hyperinsulinemia, and that's key, because he's the first person who draws attention to the role of high insulin levels in causing heart damage. And if you go to a textbook of medicine, you will not see anything about high insulin causing damage. If you go and look at all the other hormones, you'll frequently see high thyroid hormone causes this, or high adrenaline causes that, or high cortisol causes that. Nothing about high insulin, for some reason. So high insulin in increasing the likelihood of an individual developing one or more of the listed consequences. He first pointed out the clustering of these abnormalities, initially designated as syndrome X, and only lately became known as the metabolic syndrome, and now renamed the Raven syndrome in honor of this giant of medicine. And the article that I've discovered, because I think it's probably the most easy to understand and the most relevant, is insulin resistance and coronary heart disease in non-diabetic individuals. And the question is whether they in fact were diabetic or non-diabetic, but that's not the issue. He describes how heart disease will develop in the face of insulin resistance and hyperinsulinemia. And so here again, this is the article just again to confirm that this is a peer-reviewed paper in a major journal of the American Heart Association related to arterial disease, thrombosis, that's blood clotting, and the biology of blood vessels. And it's a journal of the American Heart Association. So this is high-powered science of the highest standard. And the model that he presents is the following: that if you are insulin resistant, you are always over-secreting insulin, and that induces syndrome X by the mechanisms I've described. That you're always storing carbohydrate as fat because you can't store it as carbohydrate. So you have to convert it to fat. You can't oxidize it easily again because you have insulin resistance. And syndrome X leads to coronary heart disease. And we know that the best predictor of heart attack risk is the presence of metabolic syndrome. 70% of patients who have a heart attack have metabolic syndrome. So we know that this link is absolutely secure. And the other side of it is that you might eventually have an inadequate insulin secretion because your insulin resistance becomes so high that even though you're over-secreting insulin, it's not enough to normalize your blood glucose concentration. So your blood glucose concentration rises, and then we would diagnose type 2 diabetes. And I showed you yesterday the best predictor of heart disease of a blood measure or a measurement is type 2 diabetes. Our hazard ratios of over 2. So there's no question of the linkage between type 2 diabetes, metabolic syndrome, and coronary heart disease. So where he advances our understanding is to show that the compensatory hyperinsulinemia, which we show in the purple color, causes these abnormalities. They cause weight gain, causes atherogenic dyslipidemia, which we've discovered at length. It causes adipose cells, fat cells, to increase in the viscera, in the abdominal region. It causes dysfunction of the endothelium, and this is terribly important because the endothelium is the lining cells of all the arteries and the capillaries. So right down the whole arterial bed, the endothelium is affected by how insulin function. We know this because the diagnosis of diabetes or at autopsy you could make, because the basement membrane changes of these occurs in the kidney and in the eye. And those are the first changes that occur. And that indicates that insulin is causing diffuse abnormalities which occur very early in the disease, and they go the length of the arterial bed. And that is because the arterial bed has insulin receptors, and excessive insulin stimulation causes the endothelium, the lining cells, to misfunction. And when they start to misfunction, and now you've got atherogenic dyslipidemia, that is how you develop plaque and how you develop heart disease. Hypertension, which is high blood pressure, high uric acid, which is gout, inflammation, dysfunction of the mitochondria, which are the energy producing cells in the whole body, and impaired exercise performance. So that's what happens. Now, why he got it wrong? He got it wrong because insulin resistance does not cause compensatory hyperinsulinemia. Listen again, insulin resistance does not cause compensatory hyperinsulinemia. A high carbohydrate diet does. And that's the problem. If you do not have, you can have insulin resistance and eat a low carbohydrate diet, you will be fine because you're not over secreting insulin, and your health will be perfect. And that is why up to 1960 or 70, we didn't have this outbursting of ill health, because we had the insulin resistant populations, but they weren't exposed to high carbohydrate diets. And as you increase the carbohydrate diet, you induce increasing levels of insulin resistance in any population, and that causes the problem. So what he didn't understand also was that you increase your insulin resistance with more insulin. And that's one of the key points about the management of type 2 diabetes or type 1 diabetes with insulin. Patients do worse the moment they put onto insulin. And this is the reason, because the insulin that you're treating the patient with makes all of these things worse. And so it's the high carbohydrate diet that is the problem. And had he identified it, he should have won the Nobel Prize. But why didn't he identify it? Because he was at Stanford. And Stanford has a large group of cardiologists. And they would have nailed him for giving unconventional advice. That's what would have happened. And he didn't have the courage to stand up to those professors because he knew it would be the end of his career. How can I say that with such certainty that he should have stood up to them? And he should have said, my advice is conventional and yours is unconventional, because he did the experiments which showed. And that's shown on the next slide. Okay, sorry, yeah, that's shown on the next slide. And these are 3 of the studies that he did in which he reduced the carbohydrate diets of people with insulin resistance. And then he looked at the effects on many of the variables we've discussed. So, in the next slide, in 1987, one of those publications, he said, these results document that low-fat, high-carbohydrate diets containing moderate amounts of sucrose within the guidelines amount of sucrose that you're allowed similar in composition to the recommendations of the American Diabetes Association. So these are dietary guidelines. And these are the conventional dietary guidelines. And what do? They have deleterious metabolic effects when consumed by patients with non-insulin dependent diabetes mellitus, that's type 2 diabetes, for 15 days. So the conventional advice was causing damage, and he proved it in 1987. Until it can be shown that these untoward effects are evanescent and that long-term ingestion of similar diets will result in beneficial metabolic changes, it seems prudent to avoid the use of low-fat, high-carbohydrate diets containing moderate amounts of sucrose in patients with type 2 diabetes. So what he's saying is that the conventional advice is damaging patients, and that is why I'm here. And that is why I spent all this money and employed all these people to give you the message. Because I'm not like Dr. Raven. I'm not going to be cowed by my profession. I'm going to stand up and be counted. The results of this study indicate that high carbohydrate diets lead to several changes in carbohydrate and lipid metabolism in patients with NIDDM that could lead to an increased risk of heart disease, and these effects persist for greater than 6 weeks. Given these results, it seems reasonable to suggest that the routine recommendation of low-fat, high-carbohydrate diets for patients with type 2 diabetes be reconsidered. And then further, in type 2 diabetes, high-carbohydrate diets compared with high monounsaturated fat diets. So now it's actually the diet that we're prescribing. He now finally tests it. They cause persistent deterioration of glycemic control. That is control of blood glucose concentration. And it's what we look for in control of diabetes, that doctors treating patients with diabetes want to get their glycemic control improved. And accentuation of hyperinsulinemia, as well as increased plasma triglyceride and very low density lipoprotein cholesterol values, which may not be desirable. So he presents this evidence to show that a high carbohydrate diet, which is prescribed by the American Diabetes Association, is hurting his patients. And he should at that point have said, that's it. I will now do clinical trials of low carbohydrate, high fat diets on large numbers of patients, and I will prove that the diet is causing harm. But he failed to do that. And in my view, he didn't continue what was his responsibility. And that's why I'm here, because I think it's my responsibility and my unique experiences I've had as a scientist and as a person with type 2 diabetes, whose father died of type 2 diabetes, who understands the condition. It's my responsibility to bring this evidence, and it has to be seen, and people have to note it, and they have to take it seriously, and not say it doesn't exist, because it does exist, and it's existed since 1987. And here he says in 1997, the basic defect in metabolic syndrome, syndrome X, the Raven syndrome, is resistance to insulin-mediated glucose disposal. If dietary carbohydrate is increased in an isocaloric diet, additional insulin must be secreted to maintain glucose homeostasis. So he's saying that in syndrome X, the condition that he described, carbohydrates are causing the problem, and you have to restrict carbohydrates. And that's 1997. And then his voice goes quiet. His voice goes quiet. He doesn't come out and say, guys, you got it all wrong. We've got to reduce the carbohydrate intake. And that's 1997. So we've wasted 20 years or so, when this was the one man who really understood the condition and who could have reversed the problem. So Raven understands that carbohydrates drive insulin secretion, the metabolic syndrome, insulin resistance. Hence, he had to conclude that restricting carbohydrates should be the key therapy for this condition. But he never undertook the research. And maybe he didn't undertake it because there was no funding, because he knew if he went to the National Institute of Health and said, I want to do this research, they would have said, we're not interested. And why is that? And again, I'm now speculating. Because the National Institute of Health is not independent of the US government. And the US, because they fund it. And the US government drives the dietary guidelines, which fund industries and ensure that the grains and the vegetable oils are produced by American farmers are sent around the world. And that's perhaps why he couldn't find funding for this research. So maybe I'm being a little unfair on him. But he didn't undertake the research. That his conclusions forced him to do. Now, Karen Zinn, you know, was here at the second hearing, and she was going to be one of our expert witnesses and may still be. But recently, she's been involved in the public writing of this article, Hyperinsulinemia, a Unifying Theory of Chronic Disease, which I gave. And it's really interesting because Katherine Croft was given data that was collected in the 1970s looking at insulin responses to glucose ingestion. So when doctors diagnose diabetes, we give patients high carbohydrate drinks and we measure their glucose response. The first person in the world to start looking at the insulin response was a Dr. Joseph Kraft. And he started doing it in the 1960s, and he collected 15,000 sample tests. He never published them in great detail. He wrote a book but didn't publish them, and he's just recently donated all that research to Katherine Croft. And the reason why that's important is because when you look at the insulin response to glucose, we realize that we completely underdiagnose insulin resistance. In other words, if as doctors one only looks at the glucose response to glucose ingestion, we underestimate the true incidence of insulin resistance and type 2 diabetes, because you can have a normal glucose response with a hyperinsulinemic response. And what Dr. Kraft showed in the 1970s is that if you have that hyperinsulinemic response, you have type 2 diabetes in development. So the importance of this work is it's going to show that there are many more people with type 2 diabetes or predisposed to type 2 diabetes in the community than we diagnose. So even if we think that 50% of Americans today have type 2 diabetes or pre-diabetes, that is on conventional testing. If we did this type of testing, we might see it's another 10 or 15 or 20%. Anyway, the point of that slide is that these are the diseases that they link to hyperinsulinemia. And I think we've probably been through them, but in other words, my point is we've discovered the article which gives you more evidence that hyperinsulinemia not just linked to the diseases I've described, but also others. So that is from their article. Those are the medical consequences of a high carbohydrate diet in people with insulin resistance. I'm not suggesting that that is proven beyond measure and is absolutely true. The point is that there is evidence in the scientific literature that all these conditions could have a basis in insulin resistance in people eating high carbohydrate diets. And that, Madam Chair, is the history of medicine today. That is it. And so if they are right, insulin resistance is the basis for most of the chronic disease that we face today. And we don't recognize it because we don't understand the role of carbohydrates and insulin resistance in causing all these conditions. Dr. Craig Thompson, who is the CEO of the Memorial Sloan Kettering Cancer Center, is on record as saying that high carbohydrate diets promote cancer, high fat diets do not promote cancer, and a high protein diet fits between the two. And that fits with our model that cancer is a carbohydrate-driven disease. This is not Tim Noakes speaking. This is one of the world authorities on cancer. And that video clip is on YouTube. And that's what he said. And that extends the argument that the reason why the cancer rates are rising with obesity is because they're the same disease. Or should I say the causation is the same. So I want to explain now how insulin resistance causes these conditions and what are the metabolic abnormalities and how do I see insulin resistance. And I see it as a genetic predisposition that progressively worsens with age as a result of high carbohydrate, high sucrose, high fructose diet and physical inactivity. And that's why I tried to show you in the first slides of myself being insulin resistant at the age of 28. And I know that these genes must be very powerful because they came straight from my father to me, and I'm aware that I passed them on to my own family. So the genes must be extremely powerful. And if we haven't discovered them yet, it's because we haven't looked hard enough. So that's the first point, the genetic predisposition, but it gets worse with age. I did not have type 2 diabetes at the age of 28, but I definitely had it at 60 or so. So it takes time. So you can have the insulin resistance, the genetic predisposition, but it takes time to develop. And the primary abnormality is that the glucose produced by the liver is excessive. And we call that hepatic insulin resistance. So all of us with type 2 diabetes are key abnormalities. We have a liver that overproduces glucose. And that is the driver. And it's really important to understand that. And the reasons why that is separate. It's not important. But the key driver is that diabetics have a liver that is overproducing glucose. And the point being, why would you want to give them more glucose when the liver's already overproducing glucose? And remember, we came in with my father's disease. He's told to eat carbohydrates, his diabetes. But he's got a liver that's overproducing glucose. Why does he need more glucose? Doesn't make sense. And he doesn't need more glucose because of his insulin resistance. So, the next characteristic is you can't store the extra carbohydrates. So the liver's overproducing glucose, but you can't store it. You can't get it into the muscles, and it can't store in the liver. So it has to go somewhere. And that means is your glucose is up, and because your glucose is perpetually up, your insulin is always rising. So you've got the hyperinsulinemia. And that's critical. I used to believe, when I was a student perhaps, that type 2 diabetes is you've got too little insulin. No, you've got too much insulin. And we only understand that because we've started measuring insulin more effectively. So we've got this high blood glucose and high insulin, and every time we ingest carbohydrates, we make it worse. And then what happens to that carbohydrate? It's converted under the effect of insulin to fat in the liver, and that's non-alcoholic fatty liver disease. And that is the biological basis for the atherogenic dyslipidemia. So I'm going to show you that it's the presence of NAFLD, which is caused by carbohydrates in the diet, that causes the atherogenic dyslipidemia. What does the diet-heart hypothesis say? The diet-heart hypothesis says that you eat fat, convert it to cholesterol, clogs your arteries. Not so. You eat carbohydrate, it's converted into these abnormal lipoproteins, causes heart disease. And that's why we had to spend so much time yesterday discussing the diet-heart hypothesis and why there was no evidence for it. All the evidence, when you look at it with an open mind, is that it's carbohydrates that drive the non-alcoholic fatty liver disease, which then cause the atherogenic dyslipidemia, which then damages the arteries over years and causes the arterial disease, which we recognize as type 2 diabetes, cardiovascular disease, and cerebrovascular disease. So, Madam Chair, you can understand why this is such a fundamental change in our understanding and how difficult it is to understand. If you've invested 50 years of your life into telling people that it's a high-fat diet that's killing us, and all of a sudden the science changes, that is a revolution in medicine. And it takes time, a long time, for that to be accepted. Yesterday was a pivotal day in science, because yesterday what happened was that Einstein's theory was proven correct. 100 years after he died, he presented it in 1916. In 2016, yesterday, for the first time, evidence was provided that he was correct, that there are gravitational waves. And what happened 1.3 billion years ago was two stars collided. And in seconds, they went from mass to energy, as he predicted. And they sent waves through the universe. And those waves were detected on September the 15th, 2015. And that day, Einstein was proved correct. Or at least the most of his theory was proved correct. And Einstein always said, it only takes one experiment to disprove me. And if that evidence hadn't been there, Einstein would have said, I'm wrong, I apologize. I helped you guys, I fooled you for 100 years, but okay, let's move on. And that's what we have to get medicine to accept. We got it wrong for 50 years. We have to change. We can't continue along a line that is just making us more unhealthy and sicker. We have to do something about it. So, it's the carbohydrates that give you this fatty liver. And that fatty liver now is under such duress that it starts producing the atherogenic dyslipidemia to add to the hyperinsulinemia. And so what happens is you reduce your production of the so-called good HDL cholesterol. Remember yesterday we said there's no such thing as good or bad cholesterol, there's only cholesterol. And it increased production of the atherogenic small dense LDL cholesterol particles. And I will present evidence just shortly to show that when you go on a high-fat diet, you reverse all these abnormalities. And I've been criticized in the media by cardiologists saying, Dr. Noakes says a high-fat diet reverses all coronary risk factors, but it does, and the evidence is there, and I'll show it to you. And how can people ignore the evidence? They have to see it.